part. So part of the commitment of being able to store the Rotoprone is that if we store it here, it's a win-win for everybody. You guys have to be core trained, and then you have to be able to place the patient, and you guys have the asset here, but then I also don't have to get up in the middle of the night to come and do the placement. So that being said, the Rotoprone is stored here. So you guys, it's plugged in. If you ever walk by and notice that it's not plugged in, please plug it in because the battery backup is only good for 2 hours, and if it's unplugged, you'll lose all possibility of being able to raise it up or do anything with it. It should be zeroed when they drop it off, but sometimes somebody said this morning that the zero doesn't always stay zero. And so you want to make sure that if you unplug it or whatever, when you get it to the room, before you strip everything off of it, you re-zero it. So all the pads are on it. The zero here is going to be on the scale function, so I would hit scale, and then hit 0. And then in a couple of seconds, you're about to zero the scale. Are you sure? I'm going to say yes. And then I'll wait for it to 0. Then I can unplug it and take it down the hall. Okay?
Y'all want to come see this? Can you see from there?
You just hit the scale function. And I have all the pads in there. The black bag is typically under the frame of the bed, so you want to take the black bag off. It's already off over there to get a true weight. And then, like I said, I tried to take the pads that we typically put on the patient, put them in there. They weigh, just so you know, all the pads that we typically have on the patient weigh about 1.5 kilograms, or 1.6 kilograms is what it was. So I'm ready to go. As far as patient preparation, you guys have protocols in the Seton system that you want to put a leave-in, Criticate Clear on the patient, on the flank, and on the shoulders, but that doesn't mean enough that they're like a baby in a bathtub where they're just saturated with it. I've seen them with like the zinc-based product on them before, not here, but we just really want to put it on the flank and on the shoulders or any other areas that you can see on the patient that look like is a potential for breakdown, or say they already have an area that's not blanchable or an area that's macerated, that you may want to cover that area because it looks like it's just going to be more, quote, prone to have breakdown, okay? So, and then you're going to put we want dry flow checks in the room, and then you're going to use a Mepilex transfer on the face, which is a very thin piece of hydrophilic paper that we can help use to protect the skin. Because we don't use anchor fast on these patients' faces, a lot of times if they're taking the patient, instead of using, there is a Dale Pharma or medical device has a ET tab called a stable lock that's made out of foam. It's like foam and Velcro. So if you use that, you don't necessarily have to use tape. But you know, when you use the tape and the patient starts to swell, it can kind of be like dental floss on their face. So I like to use like a Copa foam or a leave-in foam or even the Mepilex foam, the thicker foam underneath the tape, so that as the patient starts to swell, and if they're prone to pin and exposure, you can't get them turned back over, and that tape starts to get tight on their face, they at least will have something to protect this peri area around here. Okay, so you might want to just incorporate that as well. So I'm going to have the dry flow checks in the room. The nice thing about you all is that if you have to transfer the patient from your hospital bed onto the Rotoprone therapy system, you can use the lift. A lot of times we have just lifted the patient up. The first patient we had here, it took us about 3.5 hours to do the initial transfer. And then another patient a week later took us 32 minutes from start to finish to transfer the patient over, get them packed in, flip them, and have them going in 32 minutes. And that's because we utilized the lift at that time. So either way, if you're going to transfer the patient from their bed over onto the Rotoprone, you want to try to exit them from the left side over. So I use the stage term exit stage left just to help you remember which side should I put the Rotoprone. I'm trying to put it the patient's left so that they transfer this way on the lateral transfer, because the head hoop opens here, and that way the lines and everything will slide right in here. If you can transfer from that side, say they already have CRRT or CVDHD going and there's just not room there for you to put that piece of equipment, then, or put the Rotoprone, you can just push this and migrate the line slowly over here and then through. One of my soapboxes is a reference to the circuit. Please do not break the circuit to transfer the patient over. I've had multiple conversations, heated debates or conversations with either nurses or respiratory therapists. It just makes it easier to disconnect the circuit and move the patient over, and although that may be true for us, it's not easier for the patient, because one breath off of a peep of, say, anything, 12, 14, 16, 18 creates a very a very bad insult or injury to the lung, because the patient with ARDS doesn't have any surfactant in their lung, which means when you pull them off the circuit, and they'll say to me, well, there's a PEEP valve, but you're still losing all the PEEP in that circuit, right, while you put the ambu bag on with the PEEP valve. So even one breath from Z, no PEEP, to 15 of PEEP, and then back to Z can create a tremendous amount of trauma to the lung that sometimes becomes unrecruitable, okay? So we want to really be careful as we're transferring the patient. It may take us an extra 20 minutes to transfer the patient. I've had patients in little bitty rooms before. It's taken another 2 hours to transfer the patient. But if that means that the patient's going to be able to get off the ventilator and get better 2 to 3 to 4 days quicker than that, certainly the easiest thing for the patient. So I am an ICU nurse is my background. I would pop the circuit off for a second or a breath, not even thinking that it was that big of a deal until I actually just did pulmonary medicine and I saw some of Gary Neiman's studies on the lung and see how damaging it is. So try to transfer the patient from their left side if you can, and try to migrate the tubing over. Obviously, mistakes happen. Sometimes the circuit gets popped off when we're transferring. I mean, I've done it before when I'm trying to get the face mask on or whatever. You just can't get it quite right and the circuit pops off. But we don't intentionally have to remove the patient from the circuit now. We try not to do that. Okay, so once the patient is, we've decided we're going to transfer the patient and we're going to use the lift. Then you really can just move these and uncrank the sides, otherwise we'll strip the whole surface down. I prefer to strip the whole surface down outside of the room and carry the pieces into the room for a couple of reasons. Number one, there usually isn't room in the room. This room there obviously would be to open these arms all the way up, strip it down. There's lots of people in the room, so it's just easier for me logistically to break it down outside of the room. So I'm going to have you guys come and put your hands on the surface so you know how to break it down. You're going to peel it like an onion. So I know Oscar and Layla know how to do this. So for some of you guys that haven't done it a bunch of times, just like a seatbelt, you pop it here. You have a handle and a knob. Okay, so here's the handle, here's the knob. You're going to let this swing down and then you're going to snap it. And I'll show you guys on that side. Here, right here.
Just as you stay on the floor,
and then snap it. So if you're having to get on the ground, this, right. So you have a handle, you grab the handle and the knob, and then the important thing to do is to snap it while it's still here, while you still have the handle. When you get old like me, squatting and bending, it can be tough on your lower back and your knees to constantly get up and down, So you never have to really bend down. If you can get this under here, snap it, and then push it under. So snap it before you push it under, okay? So you grab the handle, pull the knob, release it down, snap it, and tuck it under. Whenever it doesn't tuck under, I showed them this morning, if you go to tuck it under and it just swings and it won't tuck, say for example, I go to push it and it just won't lock up. If I grab this bar right here and turn it toward me, it will lock it into place, okay? But 9 times out of 10 it will lock it into place. The problem with leaving them hanging is that if you move the surface down and the pack is up against the frame, it will buckle this side thing or it can burn the motor out in the rotoprone, and that's a very expensive error to make. So we want it all tucked under. The side rails come off. If you pull the grenade pin here, I call this grenade pin, except for that my soldiers that I have over at the Army Hospital tell me, don't say pull the grenade pin. Pull, and then lift, and the whole side rail will come off, okay? So you can, if you look at the side rail, you can see one side of it is convex and the other side of it is concave. That's going to be for a specific body type. If you look at this side here, how it is. It's curved in this way. This one is curved out on this side. So I would put this next to a patient maybe that had a larger belly, or a woman that had hips, or maybe a fundus, somebody that had a fundus that I'm trying to compensate for. Where the other side might be for somebody that's thin, or could be for somebody that's a really large person that's built like a box, the same size all the way up. Okay, so we want to just kind of box them in where this may not accommodate them as well. And then on the bottom you can see that there's an inner and an outer place to put the footing on this side rail into that, so you want to make sure it's on the same side on both sides, okay? So if it's on the inside here, you want to put it on the inside there. If it's on the outside there, you want to put it on the outside there, okay? Once I've made the decision which side I want next to the patient, so if I was going to put this side next to the patient, I would unbuckle these. I can just swing this around, and now the side rail can go on that side, and this side can be next to the patient. Does that make sense? So either side can be used. You can interchange them. Sometimes I'll go in, and somebody else will have placed a patient. I'll be like, that patient just does not. It's not a great fit, and I'll do something as simple as switching the side rails over, and then they'll have a much better fit, okay? So this drops like a ball in a socket whenever you replace it, so just be mindful that the ball has to be inside of the socket to lock it into place, okay? So I would bring this in the room, or whatever side I'm going to put next to the patient is the side of the room that I'll put it on when I rebuild it, just so it's more efficient, okay? These come out by turning this half a turn here. And then these move up and down by turning half a turn. So you pull this out, turn it half a turn, and then you can move this up and down, okay, to accommodate for the patient's height. The height is 4'6" to 6'6", but we have had patients that are taller than that. And then patients that might have been 6'6", but maybe they're bilateral amputees. I've had a couple of very contractured patients that I had one little boy that looked like a butterfly. His arms were contractured in, his legs were contractured in. So it really just depends on the patient whether or not we can fit them in. If they are 6'6" or taller, a lot of times we'll have to take the foot packs off, and then we can just put pads here like this to help to protect the feet. Okay. So I think somebody said a couple weeks ago you all had a patient that you had to drop these foot pads on because they were too tall. Sometimes if the patient's also say 6'7", we can get to their knees, by putting a pad underneath their knee and being able to get them into the prone position. So it's nice you guys have we have a lot of experts on our team that have been with the company for quite a long time that have a lot of experience doing kind of unusual placements. So all of your pads are going to be in the bag that are right here. Okay. So once you get the unit completely stripped down. Okay, so for you guys, if you're going to use your lift, you could lift the patient and drop the patient in. Otherwise, you need to take all the pieces off so that you have a clean surface to transfer the patient on. So I'm going to turn this half a turn and unlock it, and then you can lift this up. There's a handle right in the gutters right here to lift it completely off, okay? So when you replace the patient, you're going to put your lines here. So your Foley can go here, your rectal tube can go here, and if the patient has chest tubes, the chest tubes can go under and over. I've had as many as 8 chest tubes before, so I had to separate them here and here, okay? Cooling blanket, all those things can come up if they're on Arctic sun. All those can come up here. The same thing with your SCDs. You can put them on the patient like you normally would, and then run your pump out the foot of the bed. Okay. All right. So I've taken the bed apart. I would say you peel it like an onion. Okay. So if you'll take that side rail off, it's already unhooked there. It's just sitting on there. Just pull it up. The head pack opens here. If you push these sides in, this will open up here. It says buckle release. The buckle's released right here, just like ski boots or skates. And then you turn to the left, and it will open up the headpiece. Had a great question this morning. Somebody said, "May I have a question?" It seems like an odd question, but I had a patient, or y'all had a patient a couple weeks ago that had a contracture, so their head was contracted to the side. So they said, "What do you do in a situation like that?" Well, you actually can pull this silver knob at the head of the bed here, and it will unlock the headpiece, and then you can lock it into place according to where the patient's contracture. This is also a good option if the patient is static prone and you're not turning the patient from side to side, but you want to give their face them a rest as far as the pressure on their face. So you can opt in the prone position to pull this out and also to pivot their head from one side to the other to give some pressure relief in that case. I would not necessarily turn the patient's head to the left when their body was rotating to the right, even though it's all moving as one unit. So just so that you have the option to know if the patient's going to be static, say they're trying to get a line in or something like that, and you want to give the patient's head a rest, you can turn it like that in the prone position as well. Okay? All right, so now I'm ready to transfer the patient. I will get all of my best friends to come and help me transfer the patient over, whether I'm lifting or transferring over. I'm going to do lateral transfer to the left, transfer the patient over. And then another question was, it seems like we get the patient in just like they need to be, but then when we put the face mask on, they're not in the right position. I said, well, what could happen is that you're placing the patient, and this is either up here, and then you go down, and they're too far, you have to pull the patient down. So